My name is Delanti Anapa. I am a PGY2 resident in the Department of Internal Medicine at CMF Altman Hospital. It is our pleasure to present to you our case report on Liebman Sachs Myo-endocarditis due to antiphospholipid syndrome. Our case begins with a 32-year-old female with a history of antiphospholipid syndrome, pulmonary embolism despite anticoagulation, and chronic kidney disease stage 3B, who presented to the emergency department due to substernal chest pressure. Initial laboratory evaluation was remarkable for an elevated serum troponin and N-terminal pro-BNP, without evidence of ischemic changes on electrocardiogram. Physical examination was grossly unremarkable, except for a new 4 out of 6 hollow systolic murmur heard best at the cardiac apex. Transthoracic echocardiogram revealed global hypokinesis with a left ventricular ejection fraction of 30 to 35%. And severe mitral regurgitation directed eccentrically and posteriorly. There was a moderate circumferential pericardial effusion, and strain value was markedly reduced. However, given worsening renal function from her baseline, she was unable to undergo coronary angiography. On day 3 of hospitalization, the patient surprisingly had a transient episode of slurred speech, with weakness affecting her right lower extremity. Magnetic resonance imaging revealed multiple acute cortical infarcts in bilateral cerebral and cerebellar hemispheres, suggestive of cardioembolic etiology. Blood cultures were negative for growth. However, further laboratory testing had turned positive for anti-cardiolipin antibodies, anti-beta-2 glycoprotein 1 antibodies, lupus anticoagulant, and of course, antiphospholipid antibodies. Transesophageal echocardiogram had revealed a 0.5 by 0.4 centimeter mobile hypodensity in the posterior leaflet of the mitral valve, highly concerning for Liebman Sachs Myo-endocarditis. The diagnosis was finally confirmed with a cardiac MRI, which revealed late gadolinium enhancement. The patient was promptly started on therapeutic anticoagulation, prednisone, and hydroxychloroquine, with significant clinical improvement and no evidence of vegetation in her follow-up echocardiogram. In summary, this was a case about a 32-year-old female who interestingly presented with chest pain and was found to have Liebman Sachs Myo-endocarditis due to primary antiphospholipid syndrome, which resulted in cardioembolic strokes. Antiphospholipid syndrome is a rare autoimmune condition with an incidence of only 5 cases per every 100,000 persons per year. It induces increased risk for arterial and venous thrombotic events, which result in unpredictable clinical presentations which can affect any organ system. Liebman Sachs Myo-endocarditis is a non-bacterial thrombotic endocarditis that is infrequently seen in primary antiphospholipid syndrome. It is often asymptomatic during the initial phase, and thus it is challenging to diagnose until a thrombotic event occurs, unfortunately. The pathophysiology behind this rare disease remains poorly understood. Immunofluorescent and immunoperoxidase staining of valve specimens have revealed deposition of immunoglobulins, including anticardiolipin antibodies, which likely induces inflammation and valvular injury, acting as a nidus for platelet thrombi and fibrin deposition to form sterile voracious vegetations. They are typically found on the mitral and aortic valve. Triple positivity of antiphospholipid antibodies, anticardiolipin antibodies, and anti-beta-2 glycoprotein 1 antibodies, as seen in our patient, confers the highest risk of developing Liebman Sachs endocarditis. Therefore, workup for hypercoagulability, along with echocardiographic imaging, is necessitated for prompt diagnosis. As seen in our patient, Liebman Sachs is notorious for recurrent thrombotic events, which could lead to permanent focal neurological deficits, justifying early surgical intervention. In contrast to infective endocarditis, which requires removal of all infected tissue, preservation of unaffected valvular tissue in Liebman Sachs endocarditis is possible in most cases. However, conservative therapy with immunomodulators and high-dose steroids may provide an equally effective and non-invasive alternative as seen in this case. Anticoagulation with warfarin with an INR goal initially of 2 to 3 should be continued indefinitely, as many of these patients can experience thromboembolic events despite anticoagulation. Moreover, it is highly recommended that serial echocardiographic imaging is done to follow resolution. This case emphasizes the importance of early detection and prompt treatment of Liebman Sachs Myo-endocarditis to significantly improve a patient's overall outcome and prevent recurrent thromboembolic events. Thank you.